Thank you for having me, and happy to have helped out. So I was given the task of discussing advances in advanced endoscopy, and it's a big topic. These are my disclosures because we're discussing EUS ERCP, which DW tends to be a main sort of forum for this field. This is a breakdown of my talk: Diagnostic EUS, ERCP, some pertinent topics within ERCP, briefly touching on necrotizing pancreatitis, and finally the role of Therapeutic EUS. It's a sort of potpourri of various topics. So the two areas I'll talk about, they were brought up. One of them was EUS-guided liver biopsy, as well as the evolving role of the EUS-guided needles. How many people in the crowd are doing EUS, or sort of, okay, excellent. So for anybody who's not in the know, the traditional EUS needles have been standard needles like the ones we use for IVs. These are shown on the left, and they have been, they were initially introduced and have been used for over a decade. But in the last few years, we've had adaptation of the IR-based needles that are shown on the right, which are biopsy needles to increase the diagnostic yield primarily, but also as a secondary goal to obtain core samples of tissue rather than single cells. And so there's a lot of interest in how well they compare to each other. There are a lot of retrospective studies on improved yield and outcome based on FNB needles as opposed to the FNA needles. But DDW this year, there were two randomized controlled trials, relatively large, with over 300 patients in this first study in each arm across multiple centers across the world. And they compared two needles, a 25-gauge fine needle aspiration needle against a 20-gauge biopsy needle, and they were able to show a increased diagnostic yield with the biopsy needle, as well as a overall on-site diagnostic accuracy associated with the biopsy needle. There was no difference in terms of diagnostic accuracy predictors based on the site. The difference is the odds ratios that you're seeing are within each needle's site. But in terms of indication, lesion size, needle passes, and the presence of pathologists in the room, there was no difference. Then there was a second Chinese study where they don't actually describe the specific brand of needle, which also showed the FNB, the biopsy needle, performing better than the FNA needle. So there seems to be a trend within the field of moving from FNA needles to the biopsy needles. They are slightly more expensive, however, that may be overcome by the fewer number of passes, potentially the lack of need for pathologists in the room, as well as the higher yield overall. There's a lot on EUS-guided liver biopsy. I can't get a sense from within our organization at UCSF if this is something that's viewed upon favorably or not. My preteen daughter likes to cringe at everything these days. I don't know if they cringe or they're accepting of this, but I think there may be a role for this in our field. I'll just summarize in one slide the number of the data that was sort of presented at DDW. EUS-guided liver biopsy, two meta-analyses, both showing it's superior to percutaneous biopsy and also to transjugular biopsy, more cost-effective in a modeling study. And then there was a whole sort of different variety of studies comparing different types of needles, but the bottom line is they all work quite well, and they do have a higher yield than the FNA needles. But the number of triads that we're getting is well in excess of what's traditionally needed. So perhaps we're going overboard in terms of our biopsy passes, and maybe we just need to do one or two passes and that'll be enough. And then the final point being that heparin seems to improve loading the needle with heparin may improve our yield as opposed to doing a dry pass. The one thing that's consistently being shown, which I point out here, is that patients do get some pain, and there was at least one hematoma. That's not necessarily any different from patients experiencing pain and symptoms after the percutaneous approach. So moving on to ERCP, it's a big topic. I'll just show you things that I found interesting that may have some high quality data too. So biliary cannulation is a big topic, stones, timing of ERCP in a population-based study, pancreatic stones, and then drainage of biliary obstruction in the setting of distal malignancy. So how many in the crowd do ERCP, just for my sense for people doing ERCP? Okay, so as you know, there's a big sort of debate on what the best approach is in difficult cannulation. This was a very nicely done randomized study out of Korea, multi-center, where they're actually comparing two different techniques for needle knife pre-cut in patients with considered high risk for cannulation, and these are typically sphincter vodi dysfunction, women less than 50, normal bile duct size, normal bilirubin. The question is, I mean, how many of these people should be really getting an ERCP? But regardless, once they are getting it, they randomize patients to two different approaches. So generally speaking, when biliary cannulation fails, there are different techniques. On the left side, you'll see two traditional techniques of getting access, whereby you get to the papillary orifice and you use a needle knife where you take a needle and freehand cut towards the bile duct, which is on the left, or you actually get into the pancreatic duct with a sphincterotome and you cut the muscle, make room, and then you try and cannulate into the bile duct. The image on the right is where we actually don't make any contact with the orifice at all, and we puncture into or cut in above the papillary orifice into the area of the mound, which is where the muscle is targeting the bile duct. So they were comparing the left two approaches to the one on the right. And here's just a pictorial sort of picture of what the different approaches involve. On the right, you're measuring the papilla and going in the middle, and then cutting downwards without actually making any contact with the pancreatic orifice, with the hope that you reduce the risk of pancreatitis. Sorry about the fuzziness on the slide, but what this showed was that in this highly powered study, there were the success rate for the conventional approach of making contact with the orifice was about 89%, but with the needle knife approach, it was 97%, which is on the right. And then about 9 patients in the traditional approach actually had to be switched over to the newer or this fistulotomy approach. Interestingly, the risk of pancreatitis in the fistulotomy approach was 0%, which is remarkable. And then in terms of the non-fistulotomy approach, there was a significantly higher risk of pancreatitis of 9%. So they were concluding that maybe that should be our first approach in difficult cannulations. The problem is, oftentimes when you start cannulating, you've already made the contact, so you've already increased that risk, but maybe we should be switching over quickly and doing a fistulotomy. Moving on, ERCP for difficult bile duct stones. These are our approaches: large balloon dilation of the biliary orifice, with basically you have the orifice shown on the left side. You dilate up with a relatively large pyloric balloon going up to 12 to 15, even 18 millimeters, depending on the size of the duct, and then removing the stone. We can do mechanical lithotripsy, and then the newer approach would be cholangioscopy-based lithotripsy. That would involve putting a cholangioscope into the duct and basically have an electrohydraulic lithotripsy probe against the stone, and under saline we basically stand on the pedal, and it's pretty much like playing a video game. You break the stone, deal with the fragments later, but keep breaking away till you have taken care of the stone. So this study out of Thailand, they did a randomized trial of patients with difficult stones where mechanical lithotripsy was was compared to the EHL, cholangioscopic lithotripsy, in patients in whom large balloon dilation was not successful in removing the stones. So we've done the large balloon dilation, and now patients get randomized into one of the two arms, either attempt a mechanical lithotripsy or cholangioscopy, so a related lithotripsy. And it's a small study, 16 in each arm, and the primary endpoint was successful sort of clearance in a single session. And in the EHL group, they were able to clear it all in one session, whereas for the mechanical lithotripsy group, they had to switch over to EHL in 6 patients. So the success rate was higher with EHL. The adverse events were not different. The duration of the procedure was also shorter, as was the need for exposure to radiation. So perhaps we should have a higher threshold for switching to directed lithotripsy using a cholangioscope, as opposed to trying for too long with the basket. In terms of timing of ERCP for cholangitis, this really isn't too much of a debate. However, this was a 30-day rehospitalization database study looking at timing of ERCP in acute cholangitis of over 4,000 patients over a 4-year period. And they compared timing of ERCP within 48 hours or up to 7 days, so 5 to 7 days. And for all-cause mortality, there was, irrespective of the severity of the cholangitis, there was a much favorable outcome in the early ERCP group. The same applied to inpatient mortality and inpatient readmission rate, or patient readmission rate. So it's somewhat intuitive, but there are still places where cholangitis patients do have to wait, especially on a Friday. They have to wait till Monday. But the message here being that they should be getting their ERCP within the first 48 hours, ideally. Length of stay was shorter, as was the overall cost of hospitalization in these patients. So they concluded that patients should be getting their ERCP sooner rather than later. Pancreatoscopy, this is actually more challenging than dealing with stones in the bile duct, but the idea is that you get a cholangioscope/pancreatoscope into the pancreatic duct and do directed therapy of the stone with EHL. This was a patient with recurrent pancreatitis in the setting of pancreas tavisum. So cannulation was challenging. However, once we were able to access the pancreatic duct, we found the stone. You can see it on the right side. There's a little side branch of the pancreatic duct. So this is a nice sort of view of what the pancreas looks like on the inside, at least in the setting of chronic calcific pancreatitis. The duct is obviously somewhat inflamed, but we keep blasting away at the stone and then eventually remove stone fragments. So the reason I bring this up was that there was this multi-center retrospective study of patients who were treated with pancreatoscopy guided lithotripsy using EHL versus laser. So once you're in the duct, you have a couple of options across multiple countries. It's like sort of a collection of various patients, about 103. And the authors found that the efficacy of laser was superior to electrohydraulic lithotripsy. However, laser is typically not easy to get a hold of in the United States. Oftentimes it's with our urology colleagues, so it needs coordination. However, the need for repeated procedures was less, and overall time per procedure was also less. It does go to the point that perhaps we should be moving away from extracorporeal shockwave lithotripsy, which can be very tedious and not very successful in the US because it's not done very well by our urology colleagues, to consider doing endoscopic therapy as a first line. There was a discussion amongst various centers, sort of lead people, about starting a randomized trial on that approach, but that's in this discussion phase. Moving on to malignant biliary obstruction, one would think this isn't much of a debate, but there is still a debate in terms of timing, the type of stents. There, conventionally, it's We have data to suggest very convincingly that metal stents are superior to plastic stents in the setting of distal biliary obstruction. There is, however, debate about what stents better, uncovered or covered. Proponents for the covered stents have argued that these have less obstruction, tumor ingrowth. However, the disadvantages are that they can migrate out of position, they can have sludge formation, and they can have risk of cholecystitis. So there was this nice randomized trial comparing covered versus uncovered stents in patients receiving neoadjuvant therapy prior to surgery for pancreatic cancer. About 120 patients, and what was found was that about 20 out of the 120 needed some sort of reintervention. There was no difference between the two groups in terms of need for reintervention, which is shown on the left. So about 80% at 6 months and about 60% what did not need reintervention at a year. However, there was a difference in terms of the indication for reintervention. So in the uncovered group, the primary reason was tumor ingrowth as predicted. And in the covered group, it was acute cholecystitis or migration. Just this month in GIE, there is another study published out of multiple US centers, a prospective study where uncovered stents have been, in that study, shown to be favorable to covered metal stents in terms of need for reintervention based on complications. So the data actually previously had been, the retrospective series were suggesting that covered stents are maybe preferable, though I think now the randomized trials are showing that it's actually the other way around. This study is similar in terms of the data outcomes. This was a registry study out of Canada looking at 3 different types of stents: covered, uncovered, and partially covered. And what was shown in this study was that, again, the need for reintervention depended on the type of stent. Covered stents migrate, and they have a higher need for intervention based on that, whereas uncovered have tumor ingrowth. Moving on briskly to necrotizing pancreatitis, big field. There was a lot of interest over the last few years. It seems to have been waning somewhat, though there is debate on what the best approach is still away from surgery now in terms of minimally invasive approaches, endoscopic versus minimally invasive surgery versus percutaneous. And then the big question becomes, how can we improve our ability to do a necrosectomy endoscopically? So there's this sort of review of all the randomized slash high quality observational studies comparing minimally invasive surgery to endoscopic therapy, 2 randomized trials and 4 observational studies. This was a meta-analysis of over 300 in each arm. And not surprisingly, based on the published literature, the endoscopic approach was favorable to the minimally invasive surgical approach, which was minimally invasive approach, which is either surgery laparoscopically or video-assisted retroperitoneal surgery in terms of mortality, morbidity, and length of stay. The other biggest advantage of endoscopic necrosectomy as opposed to the other approaches is that the fistula formation rate is much lower. So again, I feel that in this day and age, the primary approach should be endoscopic plus minus percutaneous if necessary, with maybe surgery as a laparoscopic surgery as a second backup, and open surgery as a last resort. There's clearly still a subset of the population of about 7 to 8% who do need open surgical intervention. What's interesting was this tool that was described from the Netherlands that has been used for necrosectomy as well as for other indications, including polyp removal. And I'll just show you on the slide. This was a 6-patient study, but what it is basically it's like a shaver. So you have a little blade that goes back and forth, oscillates, and it also has a suction to it. And they had a nice video and case series of these 6 patients with necrosis in whom They use this tool to get rid of the necrotic tissue and basically facilitate necrosectomy. One of the challenges with endoscopic necrosectomy is the lack of good tools and spending up to a couple of hours and not getting very far. So this example here is a picture of a polyp that's been used. It's been approved in the US for polyp resection, but not for necrosectomy, but I'm sure we'll be seeing more on that. Finally, moving on to therapeutic endoscopic ultrasound. This is an exciting field for those of us who do endoscopic ultrasound. Basically, now we have the ability not just to make a diagnosis, but actually to be able to go across barriers, whether that's the bile duct, gallbladder, bowel to bowel, and that allows us to achieve a lot more endoscopically that we could not do in the past. So the lumen opposing metal stent that I believe most of us are familiar with, it's a biflanged stent, and that has been used, as you can see, from left to right, to drain the gallbladder endoscopically into the small bowel. In the middle picture, to drain the bile duct into the small intestine, and then on the right side, for patients who are considered non-surgical candidates, to bypass the gastric obstruction. So we have a stent at the end of the scope between the stomach and the small bowel, which is filled with contrast. So there seems to be a growing body of evidence for this approach for various indications. This was a nice study out of Korea. It's a randomized trial comparing primary bile duct drainage using this approach versus ERCP. And in this study of 125 patients, what they found was that the technical success between both groups was similar. Clinical success was similar. The adverse event rate was in favor of the EUS-guided approach, which is somewhat of a surprise to me because when these patients do have complications related to the procedure, the risk is peritonitis. However, this is being offset, of course, by a higher risk of clinical success. So these are clearly people who are very comfortable doing the procedure, and lower rate of pancreatitis, which is the main concern when we do ERCP. The rate for reintervention was also lower, and stent patency was also better, as well as quality of life. So overall, based on this study, there may be a growing body of evidence to support this approach. GIE had a paper out of Florida Hospital just last month, where both approaches were found to be somewhat equivalent, but with slightly higher rates of complications. In terms of gallbladder, this was drainage. There was a registry study from multiple countries of over 370 patients. And what they found was that the overall success rate of gallbladder drainage endoscopically was over 90%. Again, these are high volume centers with providers with experience. Complication rate was described as about 10%. And the factors that when they looked at associated with lack of clinical success, one of the factors that came up was the experience of the endoscopist. So having placed less than 25 in their career was associated with a higher risk of complications. Finally, EUS-guided gastrojejunostomy. There's a single center study of about 100 patients where they looked at patients with gastric outlet obstruction who were treated with endoscopic enteric stents versus endoscopic ultrasound-guided gastrojejunostomy, and the clinical success was 100% in both groups. However, the stent failure, the technical success was 100%, but the clinical success was higher in the EUS gastrojejunostomy versus enteric stents, suggesting that these stents function better because you're completely bypassing the obstruction. You don't have the stomach becomes gastroparetic in prolonged obstruction. You're just bypassing that, and there's a direct conduit from the stomach into the small intestine, so food can get through easier, and you don't have issues related to stent occlusion. Adverse events tend to occur in this study more so in the enteric stent population. The other area which somewhat sort of overlaps with Rabindra's talk is the the use of this approach to reverse the bypass in gastric bypass patients to complete ERCP. So this is very controversial for understandable reasons, but you're basically putting a stent across either the pouch or the efferent limb into the gastric remnant to complete your ERCP. I have only done it in the indications for patients with malignancy, and one benign patient who told me that between her procedure and her subsequent follow-up, she had put on 15 pounds of weight, which was very alarming. So clearly this is a concerning factor. However, at other centers, they seem to be doing it more, and there were a bunch of studies that were advocating for the use. In this study, they looked at the various factors in terms of success for two approaches, one either going from the pouch into the bypass stomach or going from the efferent limb, that's the two red arrows, so going either from the stomach to the stomach or from the jejunum to the stomach. And what they found, which is shown in bold, is that the rate of complications was higher if you go gastrogastric. If we go from the jejunum into the stomach, the risk of complications seems to be lower. So they suggested that the preferred approach in these patients may be the jejunal approach. A second study looked at the cost utility of this approach versus doing the traditional enteroscopy approach, ERCP, and seeing which approach is better. And the way they designed it was that patients either got enteroscopy as a first step, and if that failed, they had laparoscopic access to the remnant, which is one of the conventional approaches, or to do the edge procedure. And in this study, the edge procedure was 100% successful using the lumen-opposing stent. In the enteroscopy group, traditionally the success rate is about 30 to 40%. Their success rate was slightly higher at 58%, but the failed patients needed laparoscopic assistance for ERCP. Head-to-head comparison wise, the enteroscopy approach was cheaper or more cost-effective. However, if you include the failures, then the cost goes up and exceeds the edge approach. So their suggestion was that the endoscopic approach using the edge procedure may be favorable. I will say that we really have to be cautious with that approach. I actually don't necessarily believe that we should be advocating for that at all. I think we should be trying to maintain the bypass. The fortunate sort of news is that overall gastric bypass has fallen out of favor, so hopefully we'll have, as time goes on, a smaller patient population to have to deal with in this regard. So in summary, I think there seems to be refinement of the biopsy needles, but we're moving towards biopsy versus fine needle aspiration. ERCP, continued sort of approaches for optimizing cannulation. Cholangioscopy seems to be playing a more significant role. Necrotizing pancreatitis, I think we have come to the point that endoscopic approaches or minimally invasive approaches are more favorable, and there's more evidence that if we can avoid percutaneous, that's better, but there are certain patients who need it. And I feel the last one is the key one here. EUS will continue to play a role in terms of therapeutics. What I did not share but is on the horizon is the role of EUS in the treatment of pancreatic cysts, malignancies, and that'll be an interesting field as it evolves. With that, I'd like to just conclude with this slide. You know, this sort of summarizes our approach generally to the data that we present. Some of it's high quality, some of it's retrospective. We just have to take that information with a grain of salt. And finally, end on this note that as people may be aware, pancreas divisium is a very difficult condition to deal with in terms of pancreatitis. There is some thought that, and a lot of controversy, whether this is true or not, that minor papillotomy, cutting the opening of the sphincter muscle or the tissue at the minor orifice, may improve patient pancreatitis. So there is this multi-center randomized controlled, multi-center sham, randomized sham trial that it has been designed, of which we will be a part of, to assess outcomes in patients who have a minor papillotomy, to assess the response both for acute pancreatitis as well as progression to chronic pancreatitis. The likely enrollment time frame for this study is in the early fall to the new year. So please do think of us if you come across patients with DVSIM and recurrent pancreatitis. Thank you for your attention. I know it's the last talk of the day. Appreciate it.
Thanks so much, Mustafa. That was a great talk, and we do have time for a question or two as we do one final computer swap for the last bit of our talk today. Any questions for Dr. Arain? Thanks, Mustafa.